What's up, fellow AMBOSSians? I'm Dr. Zeb, back with another question walkthrough involving complications of diabetes mellitus and hyperglycemia. You're going to get several questions on your exam related to these topics, so I'll do my best to cover the most high-yield info as briefly as I can. If you find this video helpful, let me know with a thumbs up or comment and subscribe for more. And without further ado, let's get started by reading the lead-in. Further evaluation of this patient is most likely to show which of the following findings. Alright, we need to figure out what this patient has. Let's see if we get lucky and have any confirmatory findings in the last sentence. Urine dipstick is positive for ketones and glucose. Okay, this is already a significant finding for building up our differentials. So let's put on our thinking caps and briefly consider how ketones are formed. In other words, ketogenesis. Ketones include acetoacetate, beta-hydroxybutyrate, and acetone. Acetoacetate is a product of fatty acid metabolism, so beta oxidation in the liver, and can transform into beta-hydroxybutyrate that is excreted in urine, or acetone that is exhaled. Acetoacetate and beta-hydroxybutyrate can be converted into acetyl-CoA, an extrahepatic tissue, which enters the TCA cycle to be oxidized for energy. When glucose metabolism meets the body's energy demands, fatty acid metabolism and ketone body formation are inhibited. But when ATP formation from glucose is insufficient, fatty acid metabolism is activated to make up for the deficit, leading to an excess of ketones that can appear in the blood, urine, and breath. So for differentials of ketonuria, we need to consider when does glucose metabolism decrease. It could be dietary related, like fasting or starvation, low-carb diets, so keto diets, or prolonged vomiting. It can occur with states of higher demands, like pregnancy and prolonged illness or stress, or endocrine conditions involving an excess hormone, such as hyperthyroidism, hypercortisolism, so Cushing syndrome, catecholamines like pheochromocytoma, or growth hormone, so gigantism or acromegaly. It can also be other metabolic conditions like diabetes mellitus, glycogen storage diseases, or renal glycosuria. Now, which of these matches also glucosuria? Obviously not dietary related or states of higher demand, as we'd expect rather deficit glucose in general, including in urine. So we're left basically with the hormone and metabolic conditions at this point. Now that we have some differentials, let's read from the top and start to narrow down our diagnosis. A previously healthy 10-year-old boy is brought to the emergency department by his mother 5 hours after the onset of abdominal pain and nausea. Over the past 2 weeks, he has also had a 4-kilogram weight loss. The mother reports that her son has been drinking more water than usual during this period, so polydipsia. Last week he wet his bed 3 times despite being completely toilet trained since 3 years of age, so secondary nocturnal enuresis, likely due to polyuria. Alright, time to break out our illness scripts. What condition classically presents with weight loss, polydipsia, and polyuria in a 10-year-old child? Exactly, diabetes mellitus type 1. So what about the presenting symptoms of abdominal pain and nausea? What should we be thinking of at this point? That's right, diabetic ketoacidosis, or DKA. If you're pressed on time, you could try to answer the question already here. But since we're here to learn and YouTube has a 12-hour limit, don't worry, I'm not going to go 12 hours. Let's see if the rest of the vignette supports this hypothesis. He appears lethargic, his temperature is 37.8, pulse is 128, respirations are 30, and blood pressure is 95/55. Physical examination shows deep and labored breathing and dry mucous membranes. Alright, what type of breathing is classically described as deep and labored? Yep, Kussmaul breathing, which is also a sign of DKA and other metabolic acidoses. Remember the mnemonic Kussmaul, as we've shown here in AMBOSS. Dry mucous membranes indicate dehydration. The abdomen is soft, and there is diffuse tenderness to palpation with no guarding or rebound. Serum studies show sodium of 133, so hyponatremia, potassium of 5.9, so hyperkalemia, chloride of 95, bicarbonate of 13, so low, likely due to metabolic acidosis, as bicarbonate binds excess protons to turn into carbonic acid, then CO2, that is exhaled to compensate. Ultimately, this forms an anion gap. Urea nitrogen of 25 and creatinine of 1.1. So a BUN to creatinine ratio greater than 20:1, indicating pre-renal azotemia, which is consistent with decreased renal blood flow due to dehydration. All of these signs are consistent with DKA. So to answer the question, which of these findings would we expect? Decreased total body potassium is correct, despite the hyperkalemia in the labs. How do we explain this paradox? There are 3 main mechanisms involved. First, the insulin deficiency that constitutes the diabetes type 1 causes hyperglycemia and resulting hyperosmolality. This triggers potassium to shift with water from cells into the extracellular space, leading to hyperkalemia and loss in urine. Next, the insulin-driven cellular uptake of potassium via the sodium-potassium pump is absent. Lastly, elevated protons and acidosis inhibit the sodium-hydrogen antiporter. This decreases the intracellular sodium gradient, which also decreases activity of the sodium-potassium pump, further increasing extracellular potassium. So even though serum potassium can be normal or even elevated, total body potassium is reduced. This is why it's especially important when treating DKA with insulin replacement, which reverses these mechanisms, to monitor potassium and be ready to supplement if it's below 5.3 and maintain between 4 and 5. This will help prevent hypokalemia and fatal arrhythmias from intracellular shifting of potassium. If serum potassium is under 3.3, insulin shouldn't even be given before potassium repletion. Now, most importantly, what do you say to your attending who asks you to administer potassium? Okay. Even though we got the question correct, let's see what we can learn or reinforce from the distractors. Increased arterial blood pH would be consistent with alkalosis, but DKA is a form of anion gap metabolic acidosis, which also explains the decreased bicarbonate as we covered in the vignette. As for increased total body sodium, DKA causes dilutional hyponatremia due to hyperglycemic hyperosmolarity. Osmotic diuresis leads to loss of water. While most sodium is preserved, there is still a net loss of sodium in urine, so we'd expect rather normal or even reduced total body sodium. Now, I was going to tell another lame joke about sodium, but nah. Regarding arterial PCO2, in response to DKA and metabolic acidosis, the body compensates by exhaling CO2, which comes from carbonic acid. As discussed with the lab values, this is formed from bicarbonate that binds protons. So altogether, we would expect a decrease in arterial PCO2. Now for hypervolemia, we already know we'd expect rather the opposite, hypovolemia and dehydration because of osmotic diuresis. This is also consistent with the patient's polydipsia, nocturnal enuresis, dry mucous membranes, prerenal azotemia, hypotension, and tachycardia. And finally, probably the trickiest distractor, a serum glucose concentration of 650 mg per deciliter. In DKA, ketogenesis and symptoms deriving from absolute insulin deficiency already start at lower glucose levels, so concentrations rarely exceed 600. However, another hyperglycemic crisis, hyperosmolar hyperglycemic state, HHS, usually presents with serum glucose greater than 600. When first learning DKA and HHS, it can be easy to get them mixed up. So it's important to remember key differences. For example, HHS usually occurs in patients with type 2 diabetes as a result of relative insulin deficiency, enough to keep ketone production in check, rather than absolute deficiency. So these patients have normal to low ketone levels, a normal anion gap, and higher pH and bicarbonate values, often even normal. So why is HHS such a bad singer? Because it can't sing ketones. You can read more about DKA, HHS, and their differences in the Hyperglycemic Crises AMBOSS article. We also have a nice flowchart on management there. As you know from my other videos, I like to briefly consider what other questions could appear on the exam for a stem like this. Other correct options could have been fruity breath from exhaled acetone, a decreased pH, or anion gap metabolic acidosis. The question writers could have asked for the diagnosis, either type 1 diabetes or DKA itself. Sometimes they'll ask for a matching set of expected lab values. Of course, they could have asked about the next best step of management, especially for step 2 or 3, which would be, IV fluids and then insulin, possibly also with dextrose if serum glucose is under 300 mg per deciliter. Note that these would also be the next steps for HHS. Making these extra associations will prepare you for any questions the MBME will throw at you for this topic. So to recap, the key takeaways of this question are: formulate differentials for ketonuria and know their pathophysiology. Suspect type 1 diabetes with a classic presentation of polydipsia, polyuria, lethargy, and weight loss in a child. Identify DKA based on common findings like acute abdominal pain, nausea, and Kussmaul breathing or hyperventilation. Know pathophysiological changes and expected lab findings of DKA, including elevated ketones leading to anion gap metabolic acidosis, total body potassium depletion due to osmotic diuresis despite normal or paradoxically elevated serum potassium. And as a bonus takeaway, know the key differences between the two hyperglycemic crises, DKA and HHS, which are summarized in this table and the AMBOSS article. All right, that's it for this question walkthrough. You're going to get several diabetes questions and at least one hyperglycemic crisis question on every step exam. You can review these topics in more depth at AMBOSS for free for 5 days. There's a link below. If you find this helpful, please give the video a thumbs up and subscribe to our channel and any of the AMBOSS or my social media links below. I'm collecting topics I can work on next, so please leave a comment if you have any questions or requests for your next exams. And as always, remember that hard work pays off, so keep it up and stay positive. You've got this.